So my topic is Intra-Op complication in THR, fracture, femur-acetabulum and GT instability. Intra-Op fractures are rare, but potentially devastating complications of total hip orthoplasty, as number of total hip orthoplasties performed annually are increasing. Post-COVID, it has increased a lot. So as the incidence of periprosthetic fracture. Incidence reported is 0.1 to 0.5% in literature for femur, and for acetabulum it is 0.3%. So normally how it happens, what is the mechanism? In proximal femur usually occurs with bone preparation, that is aggressive rasping, and prosthetic insertion may occur during implant insertion from dimension mismatch. And middle region fracture usually occur when excessive force is used during surgical exposure or bone preparation. And distal fracture usually occur when tip of the straight stem prosthesis is impacting at the femoral bow. So there are multiple risk factors. You need to assess it pre-operatively so that you can go slowly while doing rasping and bone preparation. It is very much important especially when you are operating in periphery or places when you don't have backup options. If you are landing up with periprosthetic fracture, you don't have any other option to do. You have to abandon the surgery and then you have to go in again. So it's better to assess X-rays, and clinically for risk factors you should know clinical background. So risk factors are osteoporosis, inflammatory arthritis, rheumatoid arthritis, ankylosing spondylitis, metabolic disorder, pre-existing bony deformities, previous trauma, congenital deformities like dysplastic hip. So classification of intraoperative periprosthetic fracture is slightly different from original Vancouver classification, which was developed to describe postoperative fractures, but it has basic is the same. So it divides the fracture into 3 zones. Type 1 is proximal metaphysis without extension into diaphysis. Type B is diaphyseal about the tip of stem, and type C is extending beyond the longest revision stem or includes the fracture of distal metaphysis. It can be subclassified into 3 types on the basis of simple cortical perforation. Subtype 2 is non-displaced lineal cortical crack, and type 3 is displaced or otherwise unstable fracture. So basically it has been classified on the basis of location, pattern, stability. Type 1 is proximal metaphysis, B is diaphyseal, and C is distal to tip. So you can see in this picture, proximally it is divided into A1, A2, A3. Diaphysis is again B1, B2, B3. Most devastating is distal C1, C2, C3. So this slide is very much important. These are the treatment options for intraoperative fracture. Sometimes you assess it on table while doing, you get that noise or you feel some instability. But sometimes you get to see in post-op X-rays. So for metaphyseal fracture type 1, if there is a slight cortical perforation, if you recognize it on table, or post-op protected weight bearing at least for 6 weeks, or sometimes bone grafting. In A2 undisplaced crack, protected weight bearing or circle-arch cabers if you detect it intra-op. But in A3 type, displaced or unstable, you need open reduction internal fixation with claw plate with conversion into long stem if implant is unstable. In diaphyseal fracture type BB1, you will mostly need cortical stud graft with or without conversion into long stem. In undisplaced, same. In displaced unstable fracture, you need lateral plate with conversion into long stem. But if fracture is distal to stem, that is C1, cortical perforation, you will need stud graft. You will require different plate than you will need in diaphyseal plate. In type C2, you will need undisplaced crack, same lateral plate, and type C3 lateral plate and stud graft. So in type 1, majority are the greater trochanter fractures. They are mostly stable, usually non-displaced and minimal displaced. If you recognize it intraoperatively, it should be fixed. If you recognize post-operatively on post-op X-rays, you should be very cautious with mobilization. At least 6 weeks, patient should be immobilized. Widely displaced or otherwise unstable fractures of greater trochanter are generally treated with open reduction and typically claw plate like this. In type 2 fractures, in case of well-fixed stable implants, open reduction with plate and screws or cortical onlay allografts and combination of both. A bowed plate to accommodate sagittal bow of the femur is preferred. Reduction is achieved by using soft tissue traction while obtaining axial rotation alignment and correct length. It minimizes soft tissue disruption and preserve vascularity. Long plates which extend to lateral femoral contact should be used. Lock screws are usually used distally in case of post-operative bone. This is how stud graft should be used. You can use cable and wire combination. Cable plate or screw plate are readily available in market. They are a bit costly, but now we have Indian versions as well. So these are some X-ray. Fortunately or unfortunately, I never came across any of such fracture in my cases. So all these are not my cases. So fine cure type C, these are well distal to stem. Treatment indication and fixation technique for these fractures are independent of femoral prosthesis. Open reduction internal fixation remains the most applicable method of internal fixation. Ending a plate at or just distal to the femoral stem should also be avoided to minimize the stress riser effect. Instead, the plate should span the fracture and overlap the zone of stem. Technique of fine cure A fracture, claw plate are typically used for fixation of greater trochanter fractures. For fine cure B, lateral plate contour proximate to accommodate trochanteric flare distally to plate should be minimum 6 to 8 holes covering a native distal femur to the fracture and extending to contralateral region. Strut allograft are reserved for situation where associated bone loss in B3 fractures. These strut grafts are secured anteriorly with cables placed proximally and distal to the fracture. For type C fracture, mainstay of the treatment is distal femur fractures in presence of femur stem is open reduction with lateral plates. Plate utilized for type C should be long enough to overlap the femoral stem. These are some examples of type C fracture. Sorry, there are some repeat slides. So, Intra-Op acetabulum fracture, these are very rare, mostly happens with uncemented implants. Intra-Op fracture can occur during acetabular exposure in a fixed ankylosed hip sometimes when you are doing in situ osteotomy, during hip dislocations, when hip is stiff, reaming of the acetabulum and impaction of the acetabular uncemented component. So classification, it has been divided by Peterson and Loven in two types. Type 1 is associated with radiographically stable component. There was no change in prosthetic position or component. Type 2 fracture was obviously displaced and radiographically loose. Medial wall fractures was the most common pattern, followed by posterior column, transverse and anterior column. The optimal treatment of periprosthetic fracture is primarily detected by component stability and fracture pattern. In the setting of stable component, stable fracture patterns are generally treated non-operatively with protected weight bearing for 6 weeks if you find it post-operatively. Fracture pattern of this type include non and minimal displaced anterior column fractures. Weight bearing is allowed after 6 weeks based on the clinical and radiological evidence of fracture healing. Surgical treatment with open reduction and internal fixation is preferred for management of unstable fractures. Typical pattern of bone eagle injury encountered in this scenario are displaced posterior column and transverse fracture. The fixation strategy, surgical approach and implants are dictated by the details of the fracture pattern and generally follow those utilized for the treatment of native acetabular fractures. If there is a stable fracture pattern, revision of acetabulum component with press fit shell utilizing multi-hole cup on either side of the fracture, there should be screw. For unstable fracture, revision with the loose acetabulum component and plating of the posterior column of the acetabulum also includes use of multiple screws, preferably on either side of the major fracture line. To summarize, it can be divided into stable and unstable. Stable fracture pattern are we can do just protected weight bearing and serial radiographs over a period of 6 weeks. For unstable, will require open direction internal fixation. For unstable component, stable fracture pattern, acetabulum component revision with multi-directional screw, like and screw fixation with sometimes bone grafting. For unstable fracture pattern, pelvic discontinuity without major bone loss can be managed with posterior column plating and acetabulum component revision. But if pelvic discontinuity is there, we will reach pelvic cage with bone grafting, cup or cage construct with bone grafting. So these are some examples of periprosthetic fractures around acetabulum. In case of pelvic discontinuity, we may require a substantial amount of bone graft with possibility of cage. To take home, periprosthetic fracture should be part of pre-informed consent. If you are suspecting fracture, you should also inform patients and relatives. If patient is bedridden, osteoporotic, you should always inform them about possibility of periprosthetic fracture. It should be part of consent. Have high level of suspicion in high risk patient when you are doing it. If you are suspecting it, confirm it before final closure with the help of CM. If in case you encounter it, Intra-Op, take a pause, check available options you have in your OT, when you, especially when you are operating an institute or when you are operating at periphery. Be brave, abandon the procedure and reoperate when you are ready with the plan B and required implants, instrument. Thank you.